It is my honor to introduce Dr. Stephen Silberstein, who is a professor of neurology and director of the Jefferson Headache Center at Thomas Jefferson University. He's a fellow of the American College of Physicians, Academy of Neurology, and the American Headache Society. He has served the Headache Society as president, treasurer, and board of directors member. And he's chairman of Headache Research Group at World Federation of Neurology. He's received numerous awards, and he's had more than 300 publications, and he's going to talk to us about mechanisms of headaches. Thank you.
Thank you for the invitation, and thank you for having me here today. What I'm going to talk about, am I doing the wrong button? Yeah, are mechanisms of headache and intracranial hypotension. I'm using the wrong one. I'm going to talk about what the different type of pain fibers are, how they're involved in pain transmission. I'm going to talk about sensitization, which may be responsible for chronification of pain. I'm going to talk a bit about what causes headache, what causes low CSF pressure, and what causes low CSF pressure headache. And two things I'm going to talk about in large detail are the concept of compliance and the drift of the hydrostatic indifferent point. Sensory nerve fibers, just from a point of view, we have the C or slow conducting fibers, the A delta and the faster conducting fibers. And if you look at pain, the first pain is from the A delta, the second pain is from the C fibers. And we need to keep this in back of our minds as we look at the different types of pain. So sharp pain is A delta, the dull, achy pain we often see with the headache disorders is often C fiber. But I think what we need to talk about is the phenomena called sensitization, which means increased responsiveness to stimuli. This results in hyperalgesia or increased pain sensitivity and allodynia, where non-painful stimuli are now painful. So, for example, the pulsations of the spinal fluid in the presence of sensitization can now be painful. There's peripheral sensitization. Best example of that is getting sunburn. And the central sensitization, which we believe is extremely important in the migraine process. So the idea with peripheral sensitization, you have fibers coming in, and they're wide dynamic range neurons, and there's central modulation. So we have continuous input of peripheral pain. The sensitization occurs in neurons, and pain may be continuous in the absence of input. And that may explain why when a person with a low pressure headache stands up and they lay down, it takes a while to get better. Things have been sensitized. With that as a background, what causes headache? Traction or displacement of pain-sensitive structures, distension of intracranial arteries, veins, or venous sinuses, inflammation, obstruction, and many people believe there's such a thing as primary sensory pain. So, we're going to pay time concentrating today on the large venous sinuses and arteries as a mechanism of pain. Intracranial pressure, as you know, what you heard earlier today, is 7 to 200. Some people argue up to 250, and it used to be said 70. I don't know why in their magnificent design they made it 60. The time the pressure is not measurable, times it's normal. And as you're aware, the most common cause is lumbar puncture. And you heard before, and I'm not going to repeat, all the potential causes of intracranial hypotension. So here's the fundamental issue. You heard earlier today that some people believed that this would be a loss of buoyancy. The brain is a ball, a pot of water, and it just falls down. I'll talk about that in a minute. Intracranial volume loss, maybe you get dilatation. But headache is aggravated by jugular compression, and that doesn't consistent with that. So let's take these one at a time. Buoyancy. The spinal fluid cushions the brain, but it's still surrounded by water or spinal fluid, And there's absolutely no evidence to support the change in buoyancy. The only way to prove that would be to look at a ball in a bucket of water, take out water. It still floats, it's still buoyant. So this is totally wrong. Well, you also heard about the so-called Monroe Kelly hypothesis, which means that the sum of brain, spinal fluid, and intracranial volume is constant inside of the head. A decrease in one is compensated by an increase in the other. Spinal fluid loss decreases spinal fluid, but not venous pressure. There's a difference, and the veins dilate, and when you stand up, they dilate more. And it's clear the dilatation of pain-sensitive intracranial venous structures is responsible probably for orthostatic headache. What's the evidence? The veins of anesthetized cats dilate. Jugular compression increases headache by putting more venous dilatation, and acute venous ascension produces pain. This is an old paper I dug out. Going from left to right, the spinal fluid pressure was lowered, and as a result of that, both the arteries and the veins dilated inside the cranium. This is an old paper from 1935 showing how lowering spinal fluid pressure in a cranial window results in dilatation of peel arteries and veins. So, there's an argument. Is it volume or is it pressure? I'm going to argue neither. I'm going to argue that it's not volume or pressure, but a change in compliance. Let's talk a bit about compliance. If you look at the volume and the pressure, you get a curve. That is the degree of, and the degree of slope is the degree of compliance. If you look at the curve above it, you see that the curve is sharper, and hence you have more compliance. As the pressure is lower, you have more compliance. As the pressure is higher, it goes, and just compare that slope to those two slopes. On the left is lower pressure, on the right is higher pressure, and you can see the slope changes. What does that mean? When you do a spinal tap and you lower the pressure, the capacity of the sacs increases. The best example is that you have a balloon. You start punching a balloon and pumping air to it. The more you put in, the harder it is. It becomes stiffer. And here's what happens. Increased compliance, increased extensibility, lower the pressure, increased compliance. So when you're blowing up a balloon, the more the air, the harder it is. That's what happens with spinal fluid. So, if you look at the different systems, if you look in the head, it's covered by a rigid skull, and compliance really depends on the compressibility in the cranial venous and capillary vessels. At the bottom, there's a lot of space around the caudal sac, and it depends on the filling of the sac, and if you increase lumbar compliance, more give, it causes the hydrostatic indifferent point to be displaced caudally. Now, what the heck does that mean? If you do a spinal tap and you get an opening pressure and you sit the patient up, the pressure increases. Now, if you then look at the point, the manometer, and find the point where that pressure is equal to the opening pressure, that's called the hydrostatic indifferent point. Spinal fluid leaks may increase lumbar compliance. There's more give. As a result of that, the hydrostatic indifferent point goes downward, and this is independent of pressure. And when you're upright, the intracranial pressure is more negative, depending on the way the HIP is decreased, and it is now believed that change in lumbar compliance alone, without a spinal fluid leak, could cause orthostatic headache. And neurosurgeons have looked at patients with orthostatic headache and very capacious lumbar sacs. They actually do an ablation of the sac, and the headaches go away. So this is an illustration. On the left, that's a patient who's had a spinal tap with an opening pressure of 150. On the right, they're sitting up, and you see the pressure is higher, but if you move it up and up and up and take the pressure at that point, the pressure is the same, 150. That is called the hydrostatic indifferent point. Now, what happens if you now produce a leak? At the bottom, you get increased compliance to the lumbar space, negative more pressure, and bang, the hydrostatic indifferent point goes down, independent of anything else. It's basically speaking, you're ballooning out the bottom, the pressure drives, and that's what happens. And that results in expansion of the intracranial veins, and hence headache. And by the way, all of these slides will be available later on download. So, let's talk about this. The lumbar dural sac compliance increases with a CSF leak. What that really means is, with a leak, there's more capacity to expand. This results in the hydrostatic indifferent point coming down. When you stand up, there's more displacement. And this is due to a decrease in addition to that of filling pressure. Cranial compliance decreases with CSF leak. That's just the opposite. The veins dilate, and as a result of that decreased CSF pressure produces venous engorgement. The walls become stiffer and less compressible. So something diametrically is opposed. With a spinal fluid leak, the bottom of the sac becomes more floppy, the top of the sac becomes stiffer. Now, the dural sac, the lumbar dural sac usually resists stretch. But what happens if you put a large hole with a needle? You expose the spinal fluid to the surrounding tissue. It has more room to expand. In addition, as I showed you in that graph, lowering the filling pressure also increases lumbar compliance. The sac collapses, become more compliant, and creates more space to accommodate the spinal fluid from up top. Now, one of the interesting things, why don't all leaks produce headache, or headache to the same extent? And people have observed, for example, that CSF rhinorrhea does not always cause an orthostatic headache. Why? In the presence of a CSF leak, the drop in the hydrostatic indifferent point is less than that due to a spinal tap. And the question is why? Think about this. The increased spinal fluid space as a result of the leak in the head should actually drive spinal fluid into the head. But decreased filling pressure makes it fall. These things balance each other, and the net result of which is, even though the pressure, the hydrostatic indifferent point falls, it doesn't fall as much as possible, and it's conceivable that you do not need to have an orthostatic headache. I'll repeat that. Patients who have intracranial leaks may not have a headache depending on the balance between what happens in the head and below. Let's talk a bit about lumbar puncture. If you do a spinal tap, the hydrostatic indifferent point goes down. Let me talk about that. Initial pressure in a spinal tap, and this is actually, I'm going to have the paper, this was done in the 30s, at the time when everybody was getting spinal taps for syphilis. This patient had a spinal fluid, 18 sitting on the side, 53 standing. By definition, the hydrostatic indifferent point is 35. I mean, 35 from the bottom, that's where the opening pressure is. They do a second LP. The pressure is now 5.5 on the side and 28 sitting. Now the hydrostatic indifferent point is 22.5, and it's moved 12.5 centimeters down. The intracranial pressure, the filling pressure, is also decreased by 12.5. Therefore, the intracranial pressure is going 12.5 plus 12.5, 25 centimeters decreased as a result of the spinal tap. When you stand, you get a marked increase in transmural venous pressure. The veins dilate, more distension due to loss of filling pressure, and acute orthostatic venous distension probably causes orthostatic headache. Again, let me illustrate this again. Normal, increased compliance of the lumbar sac, the hydrostatic indifferent point goes down, and you start to get headache. This explains why, if you do a blood patch in the lumbar area, independent of blocking the hole, you get immediate relief of a lumbar puncture headache or a CSF headache because you decrease the compliance of the lumbar sac. Now, the other interesting phenomena is what happens if you have a leak in the cervical area. The cervical subarachnoid space differs from the lumbar. Lumbar space collapses, but the cervical space expands when you do a Valsalva maneuver. The opposite may occur in low-pressure headache. Look at the displacement of the indifferent point. With a cervical CSF pressure decreases, the dura collapses, the cervical epidural veins dilate, and the cervical compliance decreases, but it doesn't compensate for the loss of lumbar compliance. What does this mean? Standing, spinal fluid from the cervical and intracranial compartments move into the more compliant lumbar sac. The cervical dura partly collapses with compensatory acute distension of the veins, and this can cause orthostatic posterior cervical pain. So one of the clues of a leak in the cervical area is the presence of postural posterior cervical pain. The intracranial veins dilate, causing orthostatic headache. Now, another very interesting phenomena. Younger children and older adults have stiffer caudal space. They have less increase in the caudal compliance with the dural tear, and the hydrostatic indifferent point is displaced less, and for that reason, old people and young people often have post-LP headache. What can I conclude? And I've talked about a lot of new things, and I was hoping to spend a lot of time with Q&A. One, we believe that the reason we get intracranial headaches from intracranial hypotension is abnormal distribution of cranial spinal elasticity. We think that increased lumbar compliance causes the hydrostatic indifferent point to move down. You get more intracranial hypotension and venous dilatation and the erect posture. This can explain the orthostatic nature of the headache. It's spinal, not cranial leakage, often produces headache. It's an imperfect correlation between the pressure and the headache, and the near absence in very young and the elderly due to increased epidural space, stiffness in these ages. Thank you. And I'm going to save time and catch up for questions because this is a difficult concept and it took me a long time to get an intuitive feel for it. We always could explain when the pressure is lower, there's increased intracranial pressure, that why didn't putting pressure on the veins make the headache go away? And now I think we have a good idea. Headache is probably due to venous expansion. As a result of a spinal tap, the sac at the bottom has more space. As a result of that, pressure falls more in the head when you stand up, producing more painful acute dilatation. These mechanisms also account for the fact it was chronicity. A post-LP or a spinal fluid leak headache can be continuous, and it takes a long time for them to go away because of the presence of sensitization of the pain-sensitive intracranial structures. Thank you. Happy to take questions. I've got a few minutes left, I think. Anybody? Sure. Stand up and ask them. Sorry.
The number of neurosurgeons insisting that spinal tap
The decubitus versus prone.
I'm sorry, decubitus versus prone?
Yes. How about the number of neurosurgeons insisting that the spinal tap should be done in lateral decubitus position, not in prone position as it is measured by radiology?
Okay, there is always an issue when you do a spinal tap with a patient on their stomach. You're going to get a number that disagrees with the patient on the side. What I do not know of any studies that have taken the same patient. I know patients where they lie on their side and sit up. I think what needs to be done is to correlate the pressure on your side and flat on your back. That would not be difficult to do. And I think we need, instead of guessing what's best, to really look at that information and find out what the pressure is. And you can actually look at it if you're on your side compared to there. Technically, it should balance, but I don't know the honest answer to that question, and I think we need to know. It's easy to do. Vince?
Yeah, Vince Martin, Cincinnati. I take care of a lot of patients with Ehlers-Danlos syndrome. Do you think it's possible that due to changes in compliance of the dura, a connective tissue disorder, that you could have decreased intracranial pressures in the absence of Ehlers?
Oh, absolutely, and I think Baron Mokri has actually reported cases of orthostatic headache without leak due to increased compliance of the lumbar sac. And those cases were cured by simply taking the lumbar sac and reducing its capacity. And that's what's nice about this theory. And it also explains the fact that you can do a spinal tap and the pressure can be normal. So it has nothing to do with the pressure, the volume, but the pressure and the volume affect compliance. And it's the change in the compliance that's primary. Sure.
But in that case, would you see an increase in production, CSF production, to make up for the increase in compliance?
The whole concept would be, could you increase CSF production to compensate for it? The problem is, if you increase CSF production greater, you could actually wind up with increased intracranial pressure. And those of you who treat increased intracranial pressure, you often know that patients who have had a blood patch, what happens to them? The pressure goes up and you have to lower their pressure. So the problem is going to be a balance. Too much production happens and leaks. You suddenly stop it, the pressure goes sky high. So I think it's a compensatory mechanism, because it already happens, but it's not curative. You need to get to the cure and then be careful for rebound hypertension. Sure.
Bernard Rowe. I take care of a lot of patients with hypermobility spectrum disorder and Ehlers-Danlos also. And there are articles in the literature recently, and a lot of them have either milder or more severe sleep disorder breathing. When we measure just a single pressure, opening pressure, that doesn't account for what happens throughout the day and even at night when they develop intracranial hypertension. So that, with normal, so-called normal.
I agree with you 100%. A single opening pressure may not be useful at all, particularly in people with idiopathic intracranial hypertension. There are a number of studies, even monitoring for an hour, shows spikes in pressure. So I think you do an opening pressure, it doesn't tell you anything about what happens with the patient over the course of time. It only gives you a moment in time.
Thank you. If your theory is correct, then people with very wide laminectomies, I suppose, lumbar laminectomies, the old days, take off, basically unroof the lumbar spine from L2 to L5 without instability should have increased incidence of headache, of postural headache, right? Because you'd expect the compliance and the dura in the larger space to be able to do that. It was just an interesting thing. I don't know if anybody in the audience
Well, it
ever
has
seen
to do with the following. With the leaks, it depends not so much on the compliance of the function of the stiffness. So if you do that and you get fibrous tissue growing in the area, paradoxically, you get increased stiffness. And the only way to really know the answer to that question would be to do a pressure volume curve by simply looking at the pressure infused saline and watch the slope of the curve. That's the only way to have an answer to that question.
Yeah, I think these are very interesting ideas on compliance. And well, two comments. First of all, I remember a paper somewhere that looked at patients who they measured the pressure prone and rolled them into lateral decubitus. And there's about a 2 centimeter water difference between those patients. So the lateral decubitus, in prone, you sort of compress your abdominal veins and it boosts the pressure. But the other question or comment I had is that a lot of patients with intracranial hypotension have posterior occipital headaches. And one of the things that we see on imaging is that the cervical epidural venous plexus distends. And there's also this phenomenon that the venous drainage from your head is different when you're upright versus laying down. It shifts from your jugular veins to your vertebral veins. So I wonder, along the lines of the compliance, if some of that occipital pain is not due to these dilated epidural veins that's causing decreased compliance, and that causes some pressure on the greater occipital nerves and the branches that come off, causing that characteristic posterior occipital pain.
I agree with you, because it's clear the cervical veins dilate. I just gave you a very simple model, but you're absolutely correct, and the same mechanism can explain pain in other locations.
Hi, Ian Carroll from Stanford. This gentleman asked about whether someone with Ehlers-Danlos with a postural headache might have that headache just based on increased compliance rather than a leak, and you said of course. But I think as a practical matter, when someone comes in with a predisposing factor for a leak and has a postural headache, you're then really asking, do they have a leak with negative imaging, or do they have just increased compliance? If they have a leak with negative imaging, you want to be patching them and trying to decide where to patch them. And if they just have increased compliance, then the only thing that's out there in the literature is a pretty big operation, which is this kind of dural reduction surgery. And I think that what it really comes down to is how sensitive you believe imaging really is. My own view is that we've seen a lot of people who have been made better by patching who had negative imaging. And I don't think we're permanently reducing their compliance without affecting some escape of fluid by doing that. And so I think as a practical matter, if you have someone who has Ehlers-Danlos, a clear predisposing factor, and they have a postural headache, I think it would be a terrible thing to assume that it might just be due to increased compliance, where the only potential cure is a highly morbid operation with very little real data behind it in a controlled setting, versus in fact giving them a trial of patches.
I agree with you 100%. I was asked a theoretical question, but if you have a risk factor for spinal fluid leak, and I think some of the other sessions are going to look into the diagnostic problems today, you have to be sure that a leak is not present. And we're going to be talking later today about what the diagnostic tools you need to find it.
I have a question. Has there ever been any studies done that epidural blood patch also reduces the problems we have with loss of hearing after accidental puncture?
Sorry.
Does epidural blood patch relieve loss of hearing related to CSF?
I don't know the answer to that, why an epidural blood patch could lead to loss of hearing.
No, the loss of hearing, from my knowledge, is a side effect like posterior puncture headache and loss of hearing on elder patients. But we always know that the epidural blood patch reduces
You have an
the
answer?
headache, but I was wondering...
Well, it's clear that you can get auditory changes from change in pressure for the same mechanism, but anybody know the answer?
I had one patient who had almost complete hearing loss for over a
Yeah.
decade on one side, and one epidural blood patch actually restored the hearing
Yeah.
function on that side.
There's no question that with both high and low pressure, you can get auditory symptoms. But I don't know the exact answer to your question.
Okay, thank you.
The perilimb of the inner ear connects to the
Yeah,
CSF.
yeah.
So if you change the pressure in your CSF, you change the...
You got the answer. Thank you.
Thank you very much, Dr. Silberstein, for this excellent lecture.